and welcome everyone. I hope you're sitting comfortably on this Saturday afternoon and you're not missing too many good sports activities. The purpose of this webinar is to be able to join globally and exchanging ideas for different ways of treating congenital hands. And we've got some really good people with some really interesting cases to share. So we'd like to teach some of the basics, maybe mention some of the tips and tricks we use. And instead of trying to cover the whole of congenital hands, we're just going to look at 4 basic areas: syndactyly, macrodactyly, polydactyly, and amniotic bands. Now, we've got some excellent panelists here. And because they have so many wonderful cases, I have picked on Nuranaha, who's from the Sheikh Hasana National Institute of Burns and Plastic Surgery in Bangladesh, Manusha Mahan, who is from Ganga Hospital in Coimbatore, and Shilu Shrestha, sorry, I can't say it, who is from the National Trauma Center in Kathmandu, to bring some cases for us to discuss. And the panel that we're discussing it with is Rob Baines from Leeds. He's a plastic surgeon in the UK. Jonathan Jones may show up, and he's the head of the overseas committee for the BSSH. Scott Ayushi, who's from Texas Scottish Rite Hospital in Dallas. And we're hoping to also have Dan Z join us from Philadelphia. So please ask questions in the chat, not in the chat, in the quick questions and answers. We have Alex and Suzanne who are helping us on running this webinar, and they will be looking out for questions and also giving you some polls, so you've got to take part as well. I'm now going to pass on to Nuranaha Lata, who will give us a case on syndactyly. Nuranaha, if you could share your screen, please. And please present.
I think you're on mute.
Yeah.
I know.
Okay.
We can hear you now, Nuranaha. Thank you.
Sorry. Can you hear me now?
Yes.
Thank you. Good afternoon. Welcome you all to BFIRST BSSH Congenital Hand Surgery webinar. I'm Dr. Noor Nahar Begum, plastic surgeon from Bangladesh. I would like to show you cases on syndactyly. Syndactyly is one of the commonest hand malformation occurring in 1 in 2,000 live birth. It may present as isolated lesion associated with other anomalies or Parkinson syndrome. Male are affected more, though unfortunately my both cases are female. My first case Aisha Siddiqa, 8-month-old girl, presented to us with shortening and incomplete fusion of the medial 4 fingers and narrowing of the first OMH of the left. X-ray finding shows metacarpal and phalanges are hypoplastic, middle phalanges are absent in left hand, and there was no bony fusion. Now, I would like to request our honorable faculty member, Dr. Rob Baines, to give opinion regarding management of this case. Mr. Rob Baines, please.
Hi, sorry, I missed how old the child was, 8 months. Obviously, I would progress with the usual congenital hand examination, check the other side, check the feet and look for other abnormalities, but I'd assume this to be an isolated abnormality. And I think one of the things is looking at the digits, there's not a lot of palmar creases, so I'd be interested to know what was the range of movement in these digits at the I know they're missing some bones, but is there any flexion at the IP joints?
Yeah, joint movement was normal, not there was no fusion.
Yeah, okay. And just the reason I was asking that is just with regards to planning markings of the separation for the syndactyly, because I usually try and use zigzag incisions where there's digit movement, whereas in cases such as apex, straight line separation I think is fine. So I would treat this as I would any other syndactyly really, and separate the border digits first with zigzag incisions. My preference for the basal flap is a kind of quadrilateral flap which has got wasted in at the sides, and I separate the digits and reconstruct any areas that I couldn't cover with the skin flaps with full thickness graft. And they usually go for the groin as a first choice, although I know that increasingly people are taking grafts from the upper limb because the skin color matches better and you're less likely to get hair. So I think any of those donor sites would be fine. Upper arm, elbow crease or wrist crease or groin. And then at a second stage, 6 months later or so, I'd separate the central ray.
Excellent. So Naranahad, would you like to show us what you did?
Yeah, thank you, sir. Actually, what we do after complete evaluation and counseling of our parents, we make a complete management plan. But here, there was first web space narrowing. So in first stage, we did first web space release and reconstruction by multiple Z-plasty, and third web space by release by modified Z-plasty and creation of the web space by rectangular flap and full thickness graft. And after 3 months, we do the second operation and release and reconstruction of the second and fourth web space by dorsal rectangular flap and full thickness graft. Here pictures of our planning. This is the first stage and this is the second stage.
That's a very, very nice result. Now, I'd like to go, if I may, to the panel and ask them, is there anybody that would do anything any differently there? Or anybody that's got any tips or tricks? Anybody tried some of the skin substitutes that you can use? And what are their thoughts about it? Because this is a very nice result from Nirana.
Yeah, the follow-up picture. And her mother sent me this picture last week. She said that her baby is doing better.
Excellent.
Thank you.
Thank you. Do you want to unshare your screen? And can I ask, Scott, would you do anything differently? Scott, you might be on mute.
I don't know how I'm sorry, I don't know how I got muted, but I would probably wait till about a year of age just for the anesthetic risk that potentially exists versus being in terms of long-term cognitive effects. The tips are separated, and the larger these digits get, the easier it will be to separate and to find out if it's worth separating them. Although I think it's a beautiful, fantastic result. I would wait until a year of age to start, and I would do the first and third web space like they did. I tend to use graft from the volar wrist crease because I think it's a better color match, doesn't get hair long term in most cases. So I tend to go to the wrist crease, but you know, the groin is certainly tried and true.
Thank you, sir.
There's one question come in from the participants. So the question is, was this a Poland's brachiosyndactyly? Was there any associated anomalies, or was that isolated?
Ranaha said it wasn't, but it is certainly the sort that you will commonly see with Poland's, and it's very reasonable that you should be examining the chest wall to check.
Yeah, we check, and we think, though this was not confirmed genetically, but clinically we think it is a case of Poland syndrome, because the pectoralis major muscle was hypoplastic on the left side in compared to right side, and the anterior axillary fold was underdeveloped. And we have planned for sort out or to confirm it is a case of Poland syndrome later.
Okay, so Alex, about 60% have completed the poll. Do you want to comment on the results at the moment?
Yeah, so it looks like, can everyone see the results? It looks like 48% of you went with a dorsal rectangular flap with a skin graft. And in second place with 29% was a dorsal winged flap with interdigitating zigzag flaps with no graft.
Yeah. I would agree with Rob's point that if somebody doesn't have any, if anybody doesn't have any joints, so that a lot of these patients with Syndactyly don't necessarily have joints in their IP joints, then you can manage with a straight line scar, which makes life a lot easier. And you are still going to need skin graft. Does anybody in the panel use either a skin substitute or a graftless technique for something like this?
I don't have any experience of using skin substitutes. I do try and do a graftless technique if I can. I don't think this case, I don't think there'd have been enough skin available to do it. Simon Kay always said that if you can pinch between the digits in the space you're trying to separate and feel your finger on the other side, there's probably enough skin to do a graftless. It generally works out, that approach.
Okay. Shall we go on to the next case from Naranaher then, please?
My second case, Maisha, 6-year-old girl, presented to us with complete fusion of the third web space of both hands and incomplete fusion of the second web space of the both hands. We do plain X-ray and there was no bony fusion. And I would like to Mr. Rob Baines to comment regarding management of this baby. She present lately at the age of 6 years.
Yeah, could we go back to the slide showing the digits again? Is there definitely no bony fusion? Because it just looks at the distal phalanx in the third web space. It just looks a bit fuzzy there, and with that middle finger, it's hyperextended at the MP joint and flexed at the IP joint, like they are fused. Is there definitely no bony fusion?
Would it alter what you did if there was, Rob?
No, probably not. It was just an observation. I mean, in general, I'd approach this in a similar way to the case. I'd always look for other congenital abnormalities elsewhere in the limb, such as Poland's we mentioned last time, although this isn't such a suspicious case for Poland's. But and then again, I would separate one web at a time with zigzag flaps and a quadrilateral flap at the base.
Thank you, sir. We also release and reconstruction by using zigzag quadrangular flap and full thickness graft. And the donor site was from the groin. And we did in stage operation here the pictures of planning and operative and immediate post-operative picture. And this is the follow-up picture, and we sent her for physiotherapy and regular physiotherapy and splinting after operation. And in follow-up, the baby is doing excellent. She can write, can hold things properly with the both hand.
That's very nice again. A lovely result again. And actually, you're not seeing the deviation towards each other that you often see if there is a complex syndactyly distally on the third web, because quite often then it's quite difficult not to get DIP joint deviation towards the web, and so you're not seeing that. So that would fit with this being a simple rather than a complex syndactyly, i.e. having no bony link in the first place, wouldn't it? Very nice. So the rest of the panel, out of interest, what sort of age would you consider operating on this child normally if they came to you as a tiny baby? Because I know that for many of you, they don't always come that young. And also, would you consider operating on both sides of the finger at one time or not? So can I ask Shilu that?
Hi, sorry, I was just away for a while, so I just missed the question.
In which case, I'll ask Scott first, and then you'll hear what the question was. So that's okay. So Scott, what age would you ideally do a simple complete syndactyly, and would you ever, in a simple complete syndactyly and a simple incomplete second next to it, operate on both sides of the digit at the same time?
I don't.
Well, I think in general, if they're not tethered at the tips in a complete one, I try to wait till 1.5 years or 2 years. But I think this one would push you a little bit because of the tethering that's going on at the tips. And you can see the deformity that was happening in the middle finger. So I would be probably, this is one I would go between 9 months and 1 year. But in general, if it's incomplete, I would wait until they're at least 1.5 years or 2 years of age, because there's no reason to go after them early. And again, because of the potential anesthetic risks. If you look at the only thing I would say, I mean, the result is beautiful. What did they do to the tip? Because the lateral nail fold, I think, is of the ring finger. I'm getting blocked now by this pole. But the lateral nail fold of the ring finger on the radial side, how did they treat that? It looks like they may have just put a skin graft on that, or did they use some sort of pulp flap or something?
Yeah, I did skin graft.
You just get, yeah. So the only thing I would say is, if you're looking at cosmetic or aesthetically wise, you can think about either doing what's called a Buck-Gramco tip flap, or taking a little bit of a composite graft from the ulnar side of the hand, just because as they get to be teenagers, that lateral nail fold can get very, very thin. And at least in the US, sometimes they come back to clinic, and even though you have a beautiful result, beautiful moving fingers, sort of that lateral nail fold where it's really thin, they don't especially care for, and that's what they pick on, even though everything else is just beautiful and the motion is great and everything else is great. So I would think of that in the complete ones, to trying to do some kind of local flap or a composite pulp flap to get it better contour to lateral nail fold.
Even so, the very proximal end is always a difficult area, isn't it, Scott? And I often find I have to go back at a later date and try and do something to bring that up a little bit. Even if you've got a good lateral nail fold, it's that junction between the proximal and the lateral nail fold is often the last bit to heal, isn't it? It's a bit of a problem to get a nice one. Have you got any tips for that?
No, I mean, I just tend to immobilize them. I wish I had a good tip for it. And also sometimes you get some of that nail fold deformity, which I think you kind of see there a little bit. And you just have to try to be as careful as you can around the nail fold and try to make those Buck-Gramco flaps, I guess as wide as you can, because otherwise it's just going to be a full thickness skin graft, which it probably is, but at least it's got some pulp tissue on it and contours the lateral nail fold better.
And Shilu, I'll ask you now. So what sort of age, if this child came to you as a baby with a complete syndactyly of the third web and an incomplete of the second, what age would you ideally do it? And would you ever consider operating on both sides of the finger at the same time?
Usually I prefer the 2 years of age for the surgery, and I won't do the simultaneously on the both sides. I would rather wait for 3 to 6 months before I operate on the other side of the finger.
Now, also, you have a very different population than we do. And I was going to ask you what, since we've asked this in the poll, when would you normally do your first dressing change? And would you do it in theatre or clinic?
So it depends on where the patient is from. If the patient is from the Kathmandu Valley, I would call them in 2 weeks' time. And if the patient is very far from Kathmandu Valley, then I would call them in 3 to 4 weeks' time. And I would do that. I would prefer to do that in the theater under the anesthesia.
Okay. And Manusha, what about you? When would you normally do your dressing changes after this sort of procedure?
We always call them back at 2 weeks. So if they are from far away place, we encourage them to stay in Coimbatore in our town, and then we call them back at 2 weeks. We usually do it under anesthesia because it gives us some time to inspect the grafts as well as clean the grafts, the excess graft trimming, all that we can do it nicely. And then we change the cast or the above elbow POP slab to a soft bulky dressing.
Yeah, I think there's some work from Rotterdam from Christiane van Nieuwenhoven, where she lives or the Syndactylys for 6 weeks. And I think in a cold climate, you can do that and take the dressing off at 6 weeks. You could do that. It's not what I routinely do, but I've gone from 1 week to 2 weeks to 3 weeks now quite commonly, and sometimes even 4. But obviously it may not be the same situation in hot climates. And yeah, that may be why there's probably a lot more dressings done in the hot climates. And I certainly find that when it gets hotter in the UK, we end up needing to go back a bit more. So I think for people listening from all over the world, you have to consider your climate when you're deciding when to do a dressing change on these patients, as you know, lots of cultural and social issues, not just what you've done surgically. Alex, do you want to just share the results of that poll?
Yeah, it's just over half, so 52%, 2 weeks in a dressings clinic, and the next most popular was 3 to 4 weeks in a dressings clinic. 17% 1 to 2 weeks in theatre, and only 3% said 6 weeks in a dressings clinic. So the majority was 2 weeks in a dressings clinic.
And Suzanne, questions?
Yeah, there's lots of excellent questions coming in. So one here, do you recommend thinning of the flaps, the dorsal rectangular flaps, and also the flaps from both fingers to reduce the graft requirement? And do you tend to get hypertrophic scars more when you've thinned the flaps?
No, usually we do not do thinning of the flap, and actually not so many patients presented with hypertrophic scar, not yet. Scar condition was good. Yeah.
Thank you.
And Scott, do you thin your flaps?
I do not. I mean, I think that can be sort of a dangerous thing. I know contour-wise, people think it might be better, but the worst thing that you can have is probably the tips of those flaps dying. And I think that may lead to hypertrophic scarring and even very thick scar. So I tend to not to sort of thin out my flaps, because I think the worst thing you can do is have death of some of that flap.
Thanks very much. We've got another question here. How often do you do a butt Gramco in small infants? Is there a certain age limit, and is it successful?
I can. I mean, I do butt Gramcos if it's a complete syndactyly. I do it almost all the time if I can. Even in infants, I tend to not operate on infants, so I'm taking them after they're about a year of age, year and a half, 2 years of age. So there's usually adequate tissue and size to do that. You know, you have to. I mean, I'm not saying that I think it's all vascularized. I think some of it's a full thickness skin graft because of how long and thin, and you know how long it is and how thin base is, but it does perform well. And I tend to do it if I can almost all the time when it's complete.
Yeah, Naranaha, could you just unshare your screen, please? And I would say the one group that I definitely do it in infants, but I wouldn't do it in
Thank you.
APERTS patients. I've found some very poor results from doing APERTS patients because they have very thin, fatty pulps, but quite flat, and you end up with a big blobby flap that looks awful on the lateral nail fold and a really deficient pulp. So I would recommend not doing it in those patients. And if you want to cheat, there's a great cheat in APERTS patients, which is when they're a bit bigger, take out a little bit of their nail bed on that side, and then you can bring the skin around. It looks much nicer. But that means obviously another surgery, but it's a very tiny one much later on. So I'm just going to share my screen a minute. Just see if I can make this work for you. No, it doesn't want to play ball. Wrong one. So this is a summary. Think about what sort of type of syndactyly we've got. Simple, complex, or complicated. Complicated being when you've got syndromic, complete or incomplete. We've talked in principles about some of the things that we would and would not do. And the timing is going to depend on a number of features. And then there's all different ways to do it. As long as you remember that the commissure, the web itself needs a flap. And you need more skin in some form, whether you steal it from a graftless technique, from the dorsum of the hand or the dorsum of the fingers, or whether you take a skin graft or a skin substitute. So now we're going to go on to macrodactyly, and that will be with Manusha talking. And I'm sorry about the rubbish picture, but Manusha hides herself so much so that she's got hardly anything online with her picture on it. And I just took a rather out of focus picture of her. There we are. Manusha, please tell us about macrodactyly. Okay.
Hello.
Hello.
I would like to thank Dr. Gill for inviting me, and really honored to have this case discussion with Dr. Scott Oshie, Dr. Rob Baines in the panel. So I'm a senior registrar in Ganga Hospital, Coimbatore, India. So the first case that I have selected for case discussion is a 5-year-old boy. As a firstborn child to his parents. It was a non-consanguineous marriage. We took a detailed antenatal history and we couldn't find anything significant in it. And the parents said that he has had one episode of debulking of the index finger elsewhere. And if you ask me what the parents thought about the options for the index finger management, I would say they were okay with even removal of the digit. So before going to what we did for this patient, I would like to ask Dr. Scott. Hello, sir. How are you?
Good.
Really glad to see you again. So what would be your line of management if a 5-year-old boy with this presentation?
Okay, great. Well, please say hello to everybody in Coimbatore. My many friends are in Coimbatore. Please say hello to me. Raj and the crew.
Sure, sir.
Hadi. So I think what you want to do is, the first thing you want to do is see how the use pattern that this kid has for the hand. I mean, I would almost guarantee that he bypasses that index finger and he uses the middle ring and little finger. And I would suggest to them that they have a ray amputation of the index finger. You can try to debulk that thenar eminence a little bit. The problem is that it's usually interposed in the muscle and it can be very difficult. But many times you have to debulk the thumb and put it in a better position to doing flexion osteotomies is sometimes required. And it depends on whether you shut the growth plates or not. And it depends on what the size is compared to the dad. This is a boy, I think. So if it's a boy, you see what the thumb length is compared to the father's. And if it's up to the length of the father's, you can shut the physes of the phalanges so they grow smaller, as well as debulking it and doing some sort of flexion osteotomy. I mean, we know that this is more than likely being a what's called a PIK3CA mutation or upregulation of PIK3CA. And it's, you know, in some of these cases, it's good to take genetic studies if it's available, because they can be altered a little bit with rapamycin medication, or even now they have a PIK3CA specific blocker. So that would be in the consideration of this, but I would definitely talk to them about doing a ray amputation, because I bet he bypasses this and wouldn't use it.
So since they had, the child had already undergone debulking of the index finger when he was smaller elsewhere. So the parents were okay with removal of the digit. So our plan was to do a reamputation of the index finger and debulking of the thumb and the thenar eminence. So on table, we also decided that we could use the flexor tendons and the extensor tendons of the removed index finger. So what we did was we augmented the FPL tendon using the FDS and the FDP, and we used the extensor indicis proprius to do an opponentsplasty, so that the thumb is in a better position and the other fingers could meet the thumb. Also, along with that, we did debulking of the palm as well as the first web and thumb. So this was done recently. So yesterday actually he came to our OPD, and it's been 1 month now. The thumb is in good position now. We took the slab out, and then we encouraged him to pick some toys, and then the parents are really happy with the result. He's able to hold because the stiff index finger was coming in his way. He was not using the hand much. So we have advised the parents to encourage him to use the hand now, and this is the final result.
I think it's a beautiful result. Fantastic. What did you do to the physes of the thumb? Did you just leave them open for now?
Yeah, we did not do any boning procedure at the moment. So we have just done some tendon procedures.
And how was the debulking in the thenar eminence? Because many times it's very difficult because that overgrowth is all intertwined inside the muscle.
Yes, we did not explore the digital nerves. We did not go that deep, but then yes, it was really bulky. So we'll keep him under close follow-up, and then if I need further debulking, we will do that when he's a little older.
Yeah, that's a really nice result. Anybody else on the panel that would have thought of doing the tendons, and particularly obviously the opponentsplasty, because these patients with median nerve distribution macrodactyly have a higher risk of carpal tunnel and problems from that. And it actually, my experience is that it's very difficult sometimes to tell if they've got it, because there's already a lot of bulk there, and so they may not be so clear. Anyone else on the panel that's used tendon transfers when they've done an index amputation?
Never had to do it, but it seems like a good idea, and I agree, this is a great result.
The question I had was with so Mustafa Mahmood has talked about getting rid of the digital nerves, particularly for the thumb, because they're generally not functional if they are affected as well, which I would guess in this case they are. I don't know if you came across the digital nerves and what they look like in the thumb. Because we've done that. We've debulked the nerves entirely, and you'd be surprised how you don't lose. We've not lost sensation from doing that. I think it's because you get radial innervation that takes over these dysfunctional digital nerves.
Yes,
great to have you, Dan. Lovely to have you. And yeah, so it'll be nice to know what Manusha does. And then, Dan, if you could then tell us what you actually do with the digital nerves exactly, that'd be great. Manusha.
Yeah. So we have had cases where the digital nerves are really big and the median nerves are huge, causing carpal tunnel compression. Features of carpal tunnel syndrome. And the next case, actually, I'll be showing you one of those cases where we have done decompression as well. But if you see in this patient, maybe it's too small to say, but then if you look at the palm and the thenar eminence, you don't see much of a bulge there. And when we come across the digital nerves in the, especially in the thumb, we leave it as such. We've seen huge digital nerves, but then we leave it as such. But as they say that if the area of distribution is also being excised, then there is, I think, there is no harm in taking the nerve supply to that area. Digital nerve, if you are taking the part of the digit also, then the sensation shouldn't be a problem.
And Dan, what do you do with the nerves exactly?
Exactly, it's hard to say when I can't be exactly in that case. But in general, what we'll do is we'll find the digital nerve. And I agree with you, sometimes for the debulking purpose, to get rid of some skin, we'll take out the central portion of the skin. And then that's mainly where the innervation is. And then that way we can sort of collapse it down from the sides. And we'll follow the nerves as proximally as we can through the hamartoma. And if you know, sometimes they're really hard to split and sometimes not. And if you can split it as high as you can get them, then that's what we'll do. And we'll follow it up through the carpal tunnel and into the forearm if we need to. So that's pretty specifically. Is that good enough, Jill?
That's lovely. And Scott, what do you do with these nerves? I think these nerves are a problem sometimes, not so much if you're amputating, but if you're not amputating, they're particularly a problem. What do you do with them?
Well, I try to follow up the side that I'm debulking on. If it's large, most of these kids have big digital nerves, so I follow it back to the bifurcation where it comes off and transect it down on one side. And like Dan said, I haven't found that they lose sensation on one side or the other. I think their fingers already have some decreased sensation in them to begin with, so it doesn't really affect their sensation. I would say that the big thing about carpal tunnel is young kids can't tell you that they have paresthesias and numbness in their fingers, and so you have to watch them. And if they're biting their fingers, or their parents say that they bite their fingers quite a bit, it can be an indication that they're having some carpal tunnel syndrome symptoms from the lipofibromatous hamartoma, the median nerve that's present, or that they shake their hands quite frequently. You know, those would be indications that you should probably open the carpal tunnel and do a release at the same setting.
Okay, Manusha, can you give us your second case, if you will?
Yes.
We've lost your screen sharing, Manusha.
Yeah, 1 second, sorry.
That's all right.
Yeah. I'm having some issue sharing it. Check again.
Okay, and some of you, while you've seen that, while we're waiting for Manusha to share, will have seen a poll, and there'll be another poll coming up after Manusha has shared this second case.
Are you able to see now?
Please join in. Yeah, we can see you now. Now it's gone again.
Yeah.
That's it.
Sorry. Yeah. So the second case I've chosen is of a 6-month-old baby who came to us. The parents brought her. She's an Indian origin living in Singapore. So when we explained to them about the options of debulking and amputation, the mother said that they want to think over again. And then though we had admitted her, they went back after a day. Antenatal history wise, there's a history of infertility, and it was an IVF baby, but they came back to us after a month. So before going to what we did, these are the pictures, the presenting pictures. So as you all know, syndactyly associated with macrodactyly is not very common, but it said that around 10% of macrodactylies have macrosyndactyly. So this is the presenting picture, as well as this is the presenting X-ray. So I would like to ask Dr. Scott Oshie again. So what would he do in such a case?
I would send it to you guys in Coimbatore. No. I mean, this is clearly a case of what's called grotesque macrodactyly. I know some people would try to salvage this. I think that if you try to split the syndactyly or do any kind of debulking, the scars will get very, very thick. I mean, these children with macrodactyly tend to make very, very thick scar in general, even hypertrophic keloid scars. So in general, even if you debulk them, they tend to make big scars. So I would be really careful on this one. For me, this is a ray amputation all the way, but I would also make sure that our hematologist looked at this child, because I think this is one, if you look in the hand, it's also large. The index finger probably is too. And even in the forearm, it looks like it's large. So it's probably something, variation we call macrodystrophic lipomatosis, and would be a good candidate for starting some rapamycin, which is a PIK3, which is an mTOR blocker, at least, and try to maybe modulate some of this growth, because I don't think surgically you're going to make it these digits anywhere in a position that they would use them. So for me, I would do a ray amputation and also try to see if we can't have our pediatric hematologist take a look at them and start medication, because I think they have that version that everything's large in the upper extremity.
Okay.
Yeah.
So Manusha, what did you do?
So actually, this child came to us around 10 years back, and the mother did not give consent for amputation, and she wanted a 5-digit hand. So we consult them, saying that it will be a long process with staged reconstructions, which needs more time and patience. They were ready for it. So at 7 months of age, when they came back after a month, they were ready for surgery and they got admitted. So what we did was we shortened the digits. We took the distal phalanx out. We harvested the nail bud graft, and as a free nail bud graft, we transposed it proximally, where we felt that it would be the right place to place it. And we have inserted it. So what we do is we de-epithelialize this so that it fits inside and the graft takes up. And this is the, you can see both the nail bud grafts that we have done, and we have sutured it. So this was one of the techniques used by my chief doctor, Raja Sabapathy, and he had published it in the British Journal of Plastic Surgery years back. And at the next stage, what we did was we separated the syndactyly and we put full thickness skin grafts. Then the child went through a series of debulkings. Here you can see the vertical osteotomy that we have done for the distal phalanx, and wedge osteotomy for the ring finger as well. You can appreciate the enlarged median nerve. So we have done a carpal decompression as well. And in one of the stages, we transposed the nail bud as well. And this is the interim result. Here you can see that she's using the thumb and the index finger more. Though the middle and the ring fingers are stiff at the IP joints, they actually they flex at the MCP joints. We have done MCP capsulotomy as well at one stage to increase the MCP flexion. She preferentially uses thumb and index finger, but the child as well as the parents are really happy with the 5-digit hand, and she's a good dancer.
That's a very, very interesting technique, Manusha, because as you say, so many patients don't want to lose one, but certainly not 2 digits. And I think a ray amputation of 2 digits is quite a significant loss if you're going to take the metacarpals of both. And if you're doing it otherwise, it's quite a non-aesthetic procedure.
Yeah, so they're really happy that she's independent, she's taking care of herself. And so, but at the same time, if you see over these years, she has undergone 9 procedures, including the latest one that we have done. So what they do is every year during their annual vacation time, holiday time, they fly to India, and then we do this. But now onwards, we have told that we will do, if the child has any specific request, then we will further debulk the fingers.
Okay, and Rob, what would you do in that situation, Rob? Oh, sorry, Manusha, I didn't realize you hadn't finished. Sorry, please.
Sorry. A few months ago, she came to us. So she's now 11 years of age. So now she wanted a little debulking at the tips, and she said that she wanted this to be debulked, the palm and the deviated middle finger to be corrected a little bit. So we did some debulking at the tips, the palm, and then at the MCP joint, what we did was we tightened the tissues, some plication of the tissues we did around the MCP joint capsule.
Lovely. Very nice. Rob, what would you do in that scenario?
I agree with Scott. You know, those digits were never going to be salvageable in terms of function, but Manusha's got a really good aesthetic result with doing what she's done. I suppose the only other thing I'd add is that this might be a case where I'd consider a toe transfer. You could do bilateral second toes, and although the appearance I don't think would be much better than what Manusha's achieved with her technique, it may be that you'd have more function in terms of movement of the digits.
All the credit goes to Dr. Rajasabapathy, so I'll convey your comments to him. Thank you.
Okay, and any comments from the rest of the panel?
Yeah, I think going back to the nerves, Jill, I think that's part of the issue in the recurrences. And I don't know, again, you know, I think if you, to Scott's point, I think if you remove, you know, it's interesting considering the tendon transfer. One of the reasons that we've been reluctant to be more aggressive with the nerve is the recurrent branch. But if you're going to do, you know, in theory, you could do an amputation, take the tendons and do an opposition plasty, and then feel more comfortable about getting rid of the whole thing because it's really not helping. It's an interesting idea.
Okay, I think you can see, hopefully you can see the poll results here, and it shows different people of what their viewpoints are and what they would normally do. I think there are some questions. We probably won't be able to get all of them. So if the panel could also look on the questions and answer some of them by typing, that would be useful. But if you could pick a couple of questions to ask, that would be useful, please, Suzanne.
Yeah, perfect. Thank you so much. Fantastic talk. So lots of questions generated. First question kind of been touched on, but if we could expand on any medication for treatment of macrodactyly. I know we'd mentioned rapamycin. Just, I suppose it'd be good to expand on doses and what kind of effect you've seen with it as well.
I think the problem with that is probably it varies from country to country what their usage is. Certainly in the UK, sirolimus can be used, which is rapamycin, but there's also Apselin, I can never pronounce it. There's another drug that is more specific and looks like it may have a better result, but at least in animal studies has suggested you may need to be on it for life. My limited experience of using sirolimus specifically for the really bad lipohydramnios overgrowths is that you do get a rebound effect when you stop. But we haven't done it on many because it is limited in the UK and where we can use it on. Scott and Dan may have another view.
Well, I think, you know, for me, when the problem with rapamycin is really you have to monitor them pretty closely. You monitor the levels, and there's potential complications like anything else because it's actually it's a chemotherapeutic medication. So the biggest problems are, you know, you get problems with your triglycerides, they can go higher, cholesterol can go higher, white count can go low, and having some mucositis, which means they have to be closely monitored because they have to stop it for a little while. But for me, at least it slows down the growth in many cases. It doesn't make it go away. I don't think there's any medication that will make this go away. But rapamycin at least is a good modulator of it, I think, and can slow it down. I agree, Joe. I think that if they stop it, you can sometimes see a rebound effect. And we don't know when that happens or when it doesn't. The specific PIK3CA blocker that you're talking about, and I can't pronounce it either, but the problem in the US even with that is that it's very expensive, like 10 to 30,000 a month. And most insurance companies in the US don't approve it for this because it's it's thought to be a chronic condition. And so we have trouble putting it on it. And there's only one sort of article that has shown that its efficacy, which is that Nature article back in 2018 or 2019. So we're just waiting for more data. But I think rapamycin is fairly safe. Our kids that see neurology for tuberous sclerosis have been on that medication all their life with a very good safety panel. But I think it's a problem with monitoring, especially in countries where they don't have good access to medical care and oncologists.
Thanks so much.
Manusha, could you stop sharing, if you will? And is there another question you'd like to cover, Suzanne, or do we do the rest on writing?
Yeah, maybe we'll answer the rest and in the interest of time move to the next one.
Okay, so if Manusha can stop sharing, I'm going to share again for a moment. And hopefully this will work. So just a summary, that macrodactyly can be progressive or static. You ought to be looking for other features because traditionally, before we knew more about the PIK3CA, the AKT1 and the PTEN mutations, we would look on clinical grounds, and with Proteus, you'd be looking for linear epidermal nevi, multiple site macrodactyly, vascular malformations, lipomata, cerebriform connective tissue nevi. For cloves, you're usually going to get scoliosis and other problems with it. And then in terms of what to do, it's very dependent on what the patients will agree or parents will agree to. And sometimes amputation is the best option. They usually don't like that as a first option, but sometimes it's the better functional one. And then it's what to do with the nerve, whether you can liposuct, whether toe transfer is a good option in selected cases. And otherwise you're debulking, you're considering epiphysiodesis, which will stop longitudinal but not growth in width afterwards. And obviously medical treatment with mTOR inhibitors we've just talked about. And I think that's probably the way forward in the future. But the question is, will it be lifelong medication like you have for type 1 diabetes? And what will be the side effects? And certainly something a bit more specific than rapamycin would be ideal. So we're going to move on now, because we've got Shulu, who has, despite illness and other factors that have made it very difficult for her, has turned up and has brilliantly got some excellent cases of polydactyly to discuss with us. So we should have a good things to talk about there. Sheila, if you could share screen and present, please.
Yes. Can you see my slides and hear me clearly?
We can see your slides, and I'm very envious of that beautiful picture.
So thank you, everyone. Namaste. I'm Shilu Shrestha. I'm an orthopedic hand surgeon from Nepal, currently working on National Trauma Center. I'll be sharing few cases of polydactyly, and I just want to say that I feel very honored to be part of this webinar. And I want to thank you for having me here, and thank you for all the great panelists for sharing your wisdom for all my cases. Thank you. So my first case is a 6 years old girl with radial side polydactyly, Wassel type 4. And she's the second child of her family, and she has normal delivery, and no other siblings has been affected like this. This is her X-ray. So I want to ask Dr. Dan, how would you proceed further? Do you also classify it as WASP classification, or do you classify it in other ways? How do you make the incisions?
Dr. Sheila, could you just see if you could advance your slides? We've got the first one with the pictures, but we haven't got we can't see so clearly the clinical pictures and the photographs.
Can you see this slide with the X-ray?
No, only on the side.
No.
You largely see the Namaste one.
I think you have to do the play the slideshow. Because right now you're on your first slide only.
Oh, your screen sharing is paused somehow.
Oh.
Okay, let me do this again.
That's it. Beautiful.
Somehow it's
Okay.
getting paused now. I think, can you see my this current slide?
We can see it beautifully now. So Dan, would you like to comment?
Sure. Is there any way to make that a little bit, well, it's okay. So, right. It's hard for me to see, but it looks like one of those is triphalangeal. The radial one looks triphalangeal, I think.
Do you want
It's
me
hard
to
for me to see.
zoom it?
I'm sorry you get to look at my forehead because I'm getting as close as I can to the screen.
It could be a delta epiphysis actually, because it could
Yes.
be triphalangeal, but I can't see another epiphysis, so I think it's actually a delta epiphysis.
Yeah, I can't tell either way. Let me see if I can make that larger. I can't. So irrelevant either way, I think that thumb is going to have to go. So we'll find out from pathology what it was. So incision wise, you're actually, the more ulnar sided thumb looks relatively straight. It's hard to tell, but that looks relatively straight. So I think what you're looking at is resecting that thumb, and you may have a collateral ligament just based on the x-ray, but I would probably keep a sleeve from the radial sided thumb just in case I can't find a collateral on that ulnar sided thumb. And then I probably would do an osteotomy, closing wedge osteotomy, just at that cora, about 2/3 of the way up of the metacarpal to straighten the metacarpal. And then I try to avoid any tendon work if I can, and I try to do everything with the bones if possible. So if I can realign the bones straight and that helps me straighten the tendons, I think that's much better than trying to straighten the tendons onto bent bones. That's my general philosophy. So.
Okay, so what did you do then, Sheila?
Do you get these cases like this late, like 6 years old?
Not many. Yeah,
we
they're
get
usually much younger.
We get some in the UK where they come from Indian background, Chinese background, where the relatives that are from India or China consider it very lucky and they don't want their child to be operated on. But when the child gets a bit older in the UK, maybe they get a difficult time in school because it's very different here and most people would have had it operated here. So then the kids start saying, please, can I have something done? I don't like being teased in school. So sometimes that's what happens here, and we'll get the older ones then.
Yeah, it's same for her, because the parents and the child was not bothered for any functional deficit, but they just want to remove it because of the cosmetic reason. Somehow this screen sharing is paused and I'm not being able to advance my slides. Let me just do this again. Okay, so can you see my slides moving?
No, we can't at the moment.
I know it's moving for me, but somehow it's not. How do I do
it's also showing that you're still not on slideshow. You're still on, oh, there you go. But it's moving the slides, not the show, if you know what I mean.
Yeah, we can now see the one where you're looking at tendons, Sheila.
Okay. So I just have to do this again and again.
Otherwise, would you like me to try and share what you sent me, Sheila? That's the other option. Oh, we've got a nice picture now. We've got a lovely picture of the end result just as you've stitched it up.
You can't see my intraoperative pictures?
Yeah, we saw those already. And now we're seeing the one where you've stitched it up and you've got the scissors on the top.
Okay, so now I'm currently showing the intraoperative pictures where the flexor tendon is bifurcated at the MCP level. Can you see that?
No, we saw that one before, and now we're on the one after that.
So it's just showing one slide and but it's not playing.
Do you want me to try and share the one you sent me? If you unshare, and I'll do that, and then you can talk through it.
There are slight changes in the slides, but I think that's the way to go for it.
Yeah. Okay. Do you want to unshare? And there you are. And I will try and share. Might need to find it a moment, but it is there somewhere. Where's there's share screen? No, it's not.
Just as a comment while you're doing that, Jill, what's interesting about doing this in a 6-year-old is you're going to see much more detail than you would in a 2-year-old. So I think it's very interesting from an educational standpoint for the surgeon to be able to see the structures in greater detail. They're just much larger, they're more defined. And so you can take that with you for the next time you do it. It's a nice learning opportunity.
Yeah, it's much nicer to see all that, isn't it, than you would normally.
I just did a pulsization recently on a 6-year-old, and I think it helped me refine my operation a little bit.
Yeah, it's quite different. There's pros and cons, I think, when you get to that age, of the good and the bad of it all. I'm trying to get this up for you, and I'm nearly there. So I'm hoping.
Go ahead.
I just wanted to ask Dr. Dan that because the child is older, do you still just suture the periosteum together with the collateral, or you would use some anchor suture to attach the collateral to the bone?
Yeah, the problem with anchors is you have to get them into the epiphysis, which can be rather difficult. The only anchor I've been able to get into the epiphysis without, and that's an older child, is a juggernaut type anchor that doesn't have, it's just suture. Otherwise, they're just too bulky, and it's a really hard shot to get it into the epiphysis. Otherwise, you're going to block growth. You're going to basically create a tether.
So we can still suture the periosteum sleeve together with the collateral like we do in the younger child.
Yeah, that's what I've done.
Yeah, so I think, can you see the screen now for Shilu's slides?
Yes,
we're good now.
Yeah, so I think that's where you were saying about the bifurcation. This one didn't come so well, but that is at the end of the procedure there.
Mm-hmm.
That was as far as we'd got, Shilu. And
Okay,
that's your end result.
Yeah. So I'm totally agree with Dr. Dan that I should have done the corrective osteotomy for the metacarpal. I didn't do it for the first for this patient, and I thought if needed I would do that later on, but then they didn't want the second procedure, so I couldn't do the osteotomy. So I should have done it on the first surgery.
Out of interest, can I ask just Rob as well? Would you have done the osteotomy, and do you do anything to the tendons, Rob?
I think I would now do the osteotomy. Yeah, I think when I first started as a consultant, I shied away from them a little bit, and like Shilu, slightly regretted it later. And I haven't seen any problems with doing an osteotomy, and you're there looking at the bone anyway. So yeah, I would. With regard to the tendon, I think it depends what's in that residual thumb. So if you find there's no FPL in the one you're leaving behind, but there is a nice FPL in the thumb that you're excising, I would attempt to put it back onto the distal phalanx, because I think, why not?
And
Scott, do you do anything with the tendons?
Yeah, I like to. I mean, I would go back and say I would do an osteotomy too. But the tendons, oftentimes, it's when you look at it, especially in an older child like this, the tendons tend to be in the valley between the two thumbs, with the insertion onto the distal phalanx being very radial many times of the flexor tendon. And if it's that way, I would try to release it and get it into a more centralized position. But sometimes it's not, like Dan said. It's just case by case, I think, and it depends, sort of where that flexor tendon sits when it bifurcates off into the radial thumb that you're taking off.
I agree. I'd probably done an osteotomy. I have a very low threshold for exploring distally to see if you've got, just as Scott says, the radial deviation. And occasionally you'll get a pollex abductus where the flexor and the extensor are joined. Quite commonly when it's a type 4 and you say they're joined, they're not actually, they're joined between the toe, but you can get it even in these, though it's more common in a thumb hyperplasia. So that's lovely. So shall we go on to your next case? Now, I'm hoping that my slideshow is the same as yours is, Sheila. Is that the next case, or did you want a different one? Yeah, that one. Okay.
So this is a case of 14 years old boy with duplication of the small finger, and he wanted to join the army later. That's why he wanted to have it corrected. So can you move the slide, please? Yeah, so this is his X-ray. So I just want to ask Dr. Dan, how would you proceed further?
Yeah, so the question is, how much motion is at that joint?
Yes,
And
pretty
is there
good.
any?
Sorry, I
It's
didn't
pretty
put
good
the-
motion.
Yes, the moment was pretty good.
Yeah, I mean, the problem that you have there is it almost looks like the better joint is in that incomplete radial phalanx, middle phalanx. And the other joint looks subluxated or dislocated, as best as I can tell. Subluxated for sure. So I think this is where we take him to the OR. We look under fluoro and we see if either of these joints is really moving, or if what's really moving is just the gap between the bones. Do you know what I mean? It's not a real joint, which may be the case. I don't know if you could determine that intra-op, but I think this is a very difficult thing because I'm not sure that the ulnar-sided DIP joint is functional or salvageable. And I think whatever you're going to do to it is going to either make it stiff or not stable. So difficult. And I think I need more information before I would decide what to do. So that's a cheating answer. But it's true. I mean, that's what I would do. Do you have a sense of where the joint was, where motion was happening?
Yeah, so I'm sorry for not keeping that picture, but I had a picture with very good grip of his finger, and his finger, his DIP joint was pretty good. And because he wanted to join army, so I had to really concerned about the scar and also the preserve the moment. So I went in, and it was actually quite pretty straightforward. There was no shared tendon. I'm sorry for I don't have the intraoperative pictures, but I just have the post-op. Can you just move the slides, please?
Trying to.
Yeah, so intraoperatively, the movement was good. And I didn't put the K wire. I don't know, I should have put it, but I didn't put the K wire. I put him on a splint for a pretty long time, almost 3 months. And so he didn't turn up. So I don't know how he's doing now, but it was around 6 weeks follow-up. And can you move the next slide, please? So you can see the movement on the DIP joint here. It has been slightly decreased after the surgery, but he was quite happy with the movement. So should I have put the K wire and or fuse the joint?
Do you have X-rays? Yeah. Do you have an X-ray of the? Which
No,
one did you take? Which one did you end up taking?
I did the radial side. I took out the radial side.
Yeah.
But I didn't have to do any work with the tendons. It was pretty straightforward. But for the joint, it was after I put the splint, it was quite in place. I was thinking of putting the K wire and ask him, and I told him after 2 weeks of wound inspection, if you are not very compliant with the splint, I would put the K wire. But this was after around three weeks plus, and he was doing quite well with the splint.
I mean, with a soldier, you're going to need that grip strength that you've maintained in that distal joint. And because he was that bit older, you're not going to have that much more growth you're not going to have any growth to affect it. Might be a bit different if they'd come age 6 months.
Mm-hmm.
What would other people have done in the panel?
I would have done the same thing.
I think it's a very nice result. So we're working, Sheila, particularly hard. And I'm hoping that we'll get to the next, whatever your next slide is in a minute.
You know, I think also while you're getting the next slide up, Sheila, you think the important thing is that you were able to maintain motion. He's not painful, and he has effectively what he wants. So I think you've accomplished all the three things that we had to accomplish.
Yeah, he's able to join the army.
Yeah, I really wish I could see him in a longer follow-up. So I don't know how he's doing.
Sheila, was it this one you wanted next?
Yes. Yeah. So this is 4 years old girl with polydactyly of both bilateral hands and bilateral feet. This is the case I haven't operated on the hand because she was much more concerned with the polydactyly and the feet because she couldn't fit in any shoe wears. Can you move on the slides, please? Yes. So she has polydactyly on both the thumb and also on the radial side, also on the ulnar side, and so her problem was more on the feet. So I didn't put the pictures for the feet, but I have started doing some resection for the feet so that she can fit in the footwear. So these are her x-rays. So I don't know if what kind of syndrome it is associated with, and I want to ask panelists, how would you proceed with the surgery on the hand? Where do you start from, or how do you manage this?
Who do you want to ask and pick on, Sheila?
I was left with Dr. Dan, so maybe I start with Dr. Dan.
Sorry, I might have some background.
I'm sorry?
No worries. It's okay. Yeah. Sorry about that. Yeah, I would look for every, I would start with looking at how many metacarpals I have and how many bases I have to each digit. And what you see is that you basically have the 5 on each side. So everything that doesn't have a base for me, as long as it's functional, then that's what I'm keeping. And everything that doesn't have a base is going away, with the exception that if there is one part that is that has better motion or better strength that doesn't have a base, then I'm going to do an on-top-plasty. So that's sort of my philosophy. So based on that, yeah. So again, you have to determine a little bit intraoperatively or through your exam what's the better finger, and you're going to preserve that with hopefully it has a base, and if not, you're going to give it a base by doing an on-top-plasty.
And you haven't operated on this one yet, have you, Sheila? Is that right?
No, I haven't operated on. I have operated on her feet, but I haven't operated on her hand.
Her feet look like they needed doing as well to get into any sort of shoes.
Yeah.
So
this is the final, very simple case. Just put it to ask if I'm missing something. This is a 4 years girl with a duplication of the small finger. And can you move to the second slide, please? So it was pretty straightforward for me. It was just a simple excision for me. So is there anything that I should be more careful for? Is it just a simple excision for you too?
I think for most of us, yes. There's a lot of debate in the world when you come to this, because they're very common in particular Afro-Caribbean ethnicities, and where they have a large number. Some people used to tie them off in the nursery. I personally don't agree with that. Some people use Liger clips on them. I'm not a great fan of that, but people that love it think it's great. I do a small surgical procedure under local in the first few months of life, if I can do it in the first 3 months. But it's the sort of thing that gets people really riled up and excited because they all have a view on it. Almost every plastic and orthopedic surgeon will have a view on the only way to do this. And they're probably all right that occasionally everything will not always work out well. Occasionally someone will get a neuroma, occasionally a clip or slip and bleed, occasionally there'll be an infection. But everybody will have a very, very strong view on what they do with that. And obviously, if you do it young, you can do it under local anesthetic. Remember, if they're not Afro-Caribbean, and particularly if there's more than just 2 limbs affected, there may still be a genetic component. And sometimes some of the genetic diseases will have a more solid type foot one and a little floppy one on the hands and so on. But just bear that in mind. Whereas in your Afro-Caribbean patient, it's very, very common. Less so in the Asian and white, and gradually less so as you're going towards that group.
Well, Jill, just to comment on what you were saying, everybody does have their own view, but I think there's a lot of data that tying it off in the nursery, that has a pretty high complication rate. I think everything else that you choose to do, I think if you're a clipper, maybe it's not that much different than tying it off, but I think you can get a little bit more proximal. And I think that's why people like it. I think, Scott, you still do that? Are you still a clipper?
Well, we clip it because, we did that study that, like you said, if you tie it off, about 21% of them got that painful neuroma. We had to go back, and when we use Liga clips, it's about 7% was our data. And for us, it's pretty easy because we can just do it in clinic. And we just wrap it up and they come back 2 weeks later, and usually it's off. If it's too wide, you can't do that, obviously. And we tend to wait. If it's a wide-based one that we can't get a Liga clip around, we wait until they're a year of age and do a small surgical procedure on them. But we definitely clip.
What I don't understand is if you get neuroma with tying them off, why you don't get neuroma with clipping them off, because both of them involve clipping across a nerve and create nerve-in scars. So that's what I don't understand.
Well, I think because when they tie them off in a nursery, it's probably not a hand specialist or someone doing it, and so when they tie it off distal in sort of the stalk, and so that portends to more of a painful neuroma. Whereas, like Dan said, with a Liga clip, we get right next to the skin, so I think we can get it closer to the skin and not as much of a stalk potential.
You've still got the nerve going through the stalk to the digit. That's what I don't understand. You see what I mean? Because
but it's probably less prominent. It's probably less prominent, Jill. Yeah.
Correct.
Yeah.
That's
right.
What P. Carter taught me to do, which is to just nibble it off with a bipolar. Well, he used to use an electrocautery, one of the manual electrocauteries, which I think is a lot of heat. We use a little bipolar and just nibble it off. I think any way that you can get as proximal to it as you can, and again, ideally avoid getting the nerve in the scar. But I think that, Scott, to your point, I think that's why the clip works, is you can get really proximal, and so it's not maybe as prominent. It may still be an aroma, but it's not sticking out.
That makes sense. Okay, we probably need to move on at this point.
That's all I have. Thank you.
Okay. So have you got any thumb duplication ones or not, Sheila? No? No. Okay. So I'm just gonna, I will just mention thumb duplication briefly. And I think we've got a poll on that as well. So I've stopped sharing that one. I now need to find something else to share. So I'm just going to share this as some learning points for you, is that your ulnar and your central and your radial polydactyly is all quite different. In your syn polydactyly is where you usually get a central additional finger between the middle and the ring fingers. And they can have some very odd joints, some very odd tendons, and some very odd vasculature, which can make them very complex to try and reconstruct. Radial polydactyly isn't as easy as everyone thinks. You can get a very, very variable beast in the radial polydactyly, and some of them are particularly difficult. And always remember, if multiple limbs are involved, particularly if it's more than two, you're much more likely to be genetic and much more likely to be syndromic. And the patient that Shilu just showed may well have something like a GLI3 mutation with Greg's syndrome, just looking at they've got the pre and the post-axial polydactyly, and they've got all four limbs involved. In terms of outcomes, there's arguments about what age is best in terms of treating some of these. Obviously, how well they do depends on if they have got a syndromic association and what the actual anatomy is. And some of these patients will be staying with you for a long while because they may actually, or they'll come very late because their family will have considered it very good luck to have these extra digits. Remember, for thumb duplication, you can use a Wassel classification or the Rotterdam one, which is a little more complicated, but much more covering most of the cases you're going to see. And Wassel, the Wassel 4 is the more common, and there's a whole variety of Wassel 4s, with the most difficult one probably being those where you have a diamond-shaped duplication with a divergent, convergent pattern. And in terms of options of how you manage, you don't just ablate, but many people will ablate and then use parts like the abductor to try and join them together. But you can have thumb duplications where you join side to side in some form, which is different modifications of the below cloquet procedure. Or occasionally, if you have a good end to one and a good proximal end to the other, you can do an on-top plastic. And these are very rare and quite complex to do. But I think Scott or Dan mentioned that just then. And remember, afterwards, you may need your therapist. And I think particularly in some of the countries like Nepal and India, they have very poor scars, and you may need them for scar management, for splintage, to help encourage movement, and also to assess whether this kid's going to do well and if there's something else different about them developmentally. And I think that's a really good role for the therapist, working out what's going on with the family, because they often won't tell the doctor, but they might tell the therapist. So if I may, I'd like to go on to amniotic bands and minutiae. And she's going to share some thoughts on those. Minutiae, if you like to share your screen.
So the first case that I have is of a 1-year-old girl with a deep constriction ring in the distal arm with wrist and finger drop. So I have actually 2 questions. One is to the expert panel, whether anybody has encountered this along with a constriction ring, peripheral nerve palsy. That would be my first question.
Yeah, we've seen it before in one case where they had a radial nerve palsy.
Okay. So at 1 year of age, what we did was we did Z-plasty of the ring in the distal arm. So the main learning points here would be that we have to excise the deep ring, the fibrotic band, and then we use really big Z-plasties. And here, as you can see, the ring has been excised and the Z-plasties have been made. And for this child, we did the whole circumferential ring in one stage. So this is what we've achieved here. Yeah. So here you can appreciate the contour of the arm. The ring has disappeared here and we've achieved a good contour. So I would like to ask whether for your case, did you do anything for the nerve palsy? Dr.
Yeah, 'cause,
Scott,
yeah, so in our case, the nerve was actually very thin. I mean, it was basically transected. So we went ahead and nerve grafted it because we saw them very early on. But I think for everybody that's sees these things, the important thing is that many times they have acrosyndactylies in the fingers also, and we get distracted by the hand and the way it appears. And we need to make sure, again, that the teaching point here is that, you know, the kid obviously had a wrist drop and signs of radial palsy or radial nerve injury. And we have to make sure we look at the whole extremity because you can get distracted by the fingers and the appearance that they many times have with amniotic disruption sequence. But yes, at the time we explored the nerve and went ahead and repaired it.
yeah.
Wei Lam has done a paper with some of the Chinese because
Yes.
they have a number, and I've also got some as well, of patients that have got nerve palsy when they've had these very deep proximal rings. And as Scott says, it's often very difficult to detect, but the work that Wei Lam has done with the Chinese suggests that the nerves themselves distal to the ring are abnormal. And that would be my experience. Nerve grafting, I've just not seen as good a result as you would normally expect with the age group that you're doing. Release, certainly, I've done nerve conduction studies and shown an improvement in electrical activity after release of the band, but not always to the level you might expect, and certainly not getting the functional recovery that you would expect after nerve grafting such a young child. And that fits with the clinical picture in Germany, where I've spoken to Ralph Habenicht, who found exactly the same. So what about other?
Yes.
Yeah. What about other members of the panel? Does anyone else got some with nerve palsy?
Yeah, we've had at least one that I can remember. You know, it's interesting, and we did graft it, and I don't recall what the outcome was. But, you know, it's an interesting point, because if this is happening in utero, then you're not going to have normal nerve development distal to the band. And it brings up the question of whether or not we would be better served with a primary neurotization, meaning transfer the graft directly into the muscle that's not working. And in this case, it would not be very far, if you think about it, as an option.
And of note for the those listening, you have to remember as well, particularly if this is the lower limb, the limb isn't going to grow normally if it's got a nerve injury. And so you're going to have limb length difference, which is cosmetically a problem in the upper limb, but it's actually functionally much more of a present in the lower limb. So Manisha, I think you've got some good outcome ideas here.
Yes. So before going to the management that we chose, I would like to mention that we have had a few more children who presented to us with peripheral nerve palsy associated with deep rings. If you see which nerve was affected, radial nerve was most commonly affected. We also had median nerve, ulnar nerve affected children. And some of them came to us after neurolysis, nerve grafting. Even one child had treatment in the US and had a neurogen tube as well. But I would say that as literature says, already 9 months has passed when the baby is born. So we can't expect much movement distally. So when we were searching the literature, we came across the article that Dr. Gill mentioned by Dr. Wei Lam, which says that there is congenital global nerve hypoplasia. I would like to mention the article here because we decided to do a tendon transfer for this. And I'm sorry, it isn't moving. So according to the paper by Dr. Wei Lam, he says that all the nerves, they measured the dimensions of all the nerves by ultrasound and said that all the 3 nerves had were smaller in size. And that made us thinking that even the tendons that we are taking as donors may be hypoplastic.
Of note, while you're trying to do that, I've also noticed that 3 of the attendees, the participants, have actually raised their hands. So they've obviously got patients that they've seen as well with these
Yeah.
very deep rings with neuropathy as well associated with it. So although we think it's rare, it sounds like quite a few people have got the odd one or two.
Yes. So what we did was we transferred the pronator teres for the wrist extension to ECRP as well as ECRL. We switched it to both. And then we used FCU for the finger and the thumb extensors. So as expected, the tendons were hypoplastic. So unlike in a post-traumatic case or any other case, here the end result that we have achieved is this much. But she has got good wrist extension, finger and thumb extension, and she's using the hand well. But unlike in a post-trauma case, we decided to advise splintage for a longer time. So the parents are really happy with the result, and you can appreciate the ones in the yellow are the post-operative scores, and the ones in the brackets are the pre-operative scores. And we measured the grip strength and the pinch strength as well. They've also better from the pre-op period. So I would like to ask Dr. Wheelam to comment on the paper that is written.
Am I allowed to, Jill?
Yeah, of course you are, Wei. I was just,
Okay.
Wheelam is the current editor of the British Journal, and he normally does all these webinars himself and just occasionally asks me to help, but he's now completely overwhelmed with work, and so I thought I'd give him a rest, but obviously he didn't want one. So there you are. You're more than welcome. Of course you are, Wei.
Yeah, so really that paper is from the Beijing group. I was collaborating with them, but they are the main authors. So I think the interesting thing from that paper was, and also searching from the literature, and I think Newford Jones published one of the previous papers some time back. If you get a constriction band at the level of the wrist, you would think that by just releasing the constriction band, the nerves will be okay. But what they found was a global nerve hypoplasia. So it seems like it's not just a mechanical constriction of the nerve at the level of the ring, but it seems like it's more of a global nerve hypoplasia type picture. So this will make me sort of think twice. When I see a constriction band, maybe in the forearm, I will start thinking that maybe more globally the nerves may be affected. So that was the main message from the paper. Thanks.
We're thinking about it from a nerve physiology standpoint. There's a big pruning event that happens around birth, essentially. And I wonder if the nerve is dysfunctional on an anterior horn cell level, you're getting that pruned. And so no matter what you're doing in terms of grafting, you may not work at all. And also your muscles themselves will be dysplastic or hypoplastic, not just atrophied, but hypoplastic as well. And so that may not be a salvageable situation. So this is a great result. And it's also interesting to note there's very little lymphedema in this patient, which I would expect with such a deep band. So
yeah,
kudos.
Thanks, Dan. I think the interesting thing is we keep debating between the extrinsic and intrinsic theory of amniotic band syndrome. And maybe this is probably pointing more towards the intrinsic theory, that it's not just an external mechanical piece of amniotic tissue causing the constriction. I think the nerve hypoplasia developed in utero is a much earlier event that somehow the nerves just did not develop very, very early on in pregnancy. And
the thing is, we don't know what time the bands have actually occurred. So it might be that the band was very early in pregnancy and therefore the signals didn't go to allow everything else to develop. Because I'd agree, I've got a patient where they've got a global nerve palsy at similar sort of level, and their muscles didn't develop, their joints didn't develop normally.
So Jill, do you think in these cases then where you've got a nerve palsy, it would be worth some imaging, like an MRI or something, to look at the distal musculature to kind of make a guess as to whether you think it's salvageable in terms of reinnervation?
Yeah, it has been something I've done. I must admit, I don't know whether it ultimately makes a difference. Certainly, if you haven't got good joints, we all know nothing does very well if the joints aren't good. and that is a problem. But I mean, you could certainly look to see if there's anything there, and the ones I've got, you see a big difference, and there's a lot less distally. What you don't know if there's something, how much you'd better build it up if you can re-innovate it well enough.
I think you can also look at the EMG. I hate doing EMGs in babies, but I think you can do this under sedation or anesthesia and look to see if there's any electrical activity in that muscle. If there's no insertional activity and no fibrillations, then I think it's a lost cause at that point.
Certainly, all the literature suggests that even if you find a hypoplastic nerve proximally and you graft it, you just don't get good results. So it may not be worth grafting, but it may be that the muscles are already so long denervated, it's not worth doing it. But it's a very interesting area. You do get, I mean, I've looked at this in the ones I've got, and you do get an improvement. It's just the question of whether it's enough to make it worthwhile. So I think, you know, that Manusha's idea of doing tendon transfers is a very reasonable one. Whether a nerve transfer would work is another question. I suppose it depends whether it's all the nerves affected and just one is more obviously so than the others, because that would make a difference, obviously. I think the jury is still out with sensation. If you get a median ulnar nerve hyperplasia, maybe worth grafting for the sensation, but I don't know what results you'll get from that. And in terms of the panel now, a lovely result there with multiple Z-plasties. What do other members of the panel do? Rob, what do you do now with a circumferential ring? Do you do it in stages? Do you do multiple Z-plasties? What do you do?
I do the whole excision in one go, and Z-plasty is pretty much the same as this case. And Dan, what do you do?
Yeah, I've gone to fewer Z-plasties, as you guys say. I'll do more of an excision transversely, and then I'll throw in maybe 1 or 2 Z-plasties just to break it up.
And Niranaha?
Yeah, I do multiple Z-plasty, but in 2 settings. In first setting half, and then another setting other half. And not full at a time.
I will do like Nurana, like I will do a multiple Z-plasty, half half before and half like after 3 or 6 months after.
And I've gone now to, I think you get a nice result on the contour, but quite extensive scarring with a multiple Z-plasty. So I've gone to more a primary excision and either a Z-plasty in the ulnar side, just where it's fairly well hidden, or even a V to Y plasty type scenario, or Y to V plasty type scenario, if I've got a circumference that's very big at the top and very small distally, just to try and reduce how much scarring, because I do think the Z-plasty gives a good contour, but is much more visible later on over quite a long area. Okay, I think we've got, it's interesting, we've got a poll there that shows what the results of the poll is, and does Alex just want to mention that?
Hi, yeah, so results of the poll just show that, well, 41% of you went with multiple Z-plasties, and then 30% went with one of the above, and doing half the circumference of the limb at a time. So that was the results.
Okay, and I think then Manusha has got another case for us.
So this is just some long-term follow-ups that we have had. You can see an infant where we have done Z-plasties. Again, it gives a good contour, like Dr. Gill said. This case has got really big distal lymphedema. So we have done Z-plasties in both the digits, and this is a 3-year follow-up. So shall I go to the next case, Dr. Gill?
Yes, please, if you will.
So this is a 5-month-old baby girl who came to us. If you can see all the 3 clinical features of constriction ring syndrome here. You have the constriction ring, you have the acrosyndactyly, you have the intrauterine amputation. And it's really complex here. The central 3 digits, they are fused to the short thumb. So I would like to ask Dr. Rob Baines what he would do with this case.
It looks like a difficult case. I think the first thing is I'd consider the first web space, which is obviously narrowed, and my aim would be to release that. And the first thing that would be going through my mind is the need for something like a free groin flap to give you adequate skin release. The next thing will be the fact that there probably isn't going to be adequate length on the thumb, and possibly the need to do something about that. And I guess the first choice would probably be a toe transfer for that. But I would want to see, at each stage how it looked, what the function was like after the separation before I made that decision. And I'd do it as a staged thing.
Dr. Gill, what would you do?
My first thing would be to try and separate off the very tips if I can. And I agree with Rob, we need to get a first web space here. I think we may find this sufficient with using some local dorsal skin to create a web space. We may find there's not. And if there's not, I'd actually consider a pedicled groin flap in a 5-month-old, because I'd be thinking about, well, I want to do a free toe later to the thumb, almost definitely. So if the parents will agree to it. So therefore, I'd rather be keeping my veins and things for later, make life a little bit easier for me later on. I'm a bit of a coward that way. But I think, in these sort of cases where there's joining distally, and it's difficult to see on the others, it doesn't look as though it is so distal. I'm inclined to separate off distally, try and get things so they're growing so I can see what I'm working with, and then go on from there. But I agree with Rob, the first web is the first priority.
Yeah. So one of the important learning, yes. So we separated the digits here. As you can see, the index and the middle, they have got really hypoplastic, very small proximal phalangeal bases. So this will be that one. This is the ring and this is the little, and here we have the short thumb, and here there is the first web. So one of the important learning points will be that we should pass a vessel loop or an artery and then go along the, because it's an acrosyndactyly, there will be native skin here. And we have to make sure that we go through the right plane. Otherwise, we can end up in having epidermal cysts and inclusion cysts and so on. So, so after the separation of the acrosyndactyly, we went in for a free toe transfer to reconstruct the thumb. Unlike in cases like transverse arrest or Syndactyly, these structures are proximal to the acrosyndactyly in a constriction ring syndrome will be all right. But we had to harvest some skin graft to cover the raw areas. And here is the child with good span of the hand. She's able to hold things. Grip is good. This is the post-operative X-ray after the toe transfer, and she's able to oppose as well and touch the little finger.
Yeah, effectively her first web is from thumb to ring finger, and it's you've got a lot more out of that than that ring finger than you were going to. I agree. We used lacrimal probes to try and see where the gaps are in the acrosyndactyly, much to the upset of the eye surgeons if I bend them. But I think these ones are really difficult to get nice looking fingers sometimes from. And of all the surgeries I do, I don't know if everyone else has this experience. It's probably one of those things where I end up doing more little surgeries to try and tidy things up and make them look nicer. Because at the end, a lot of the time, you can't make it look as nice as you want to. That's my experience.
Yeah.
What about other panel members? Scott, any thoughts?
No, I agree with you. There's always, these are those cases just like cleft lips and palates. There's always something little that you can do because they have some, band deformities, and you're trying to make their fingers look as normal as you can. So I agree totally what you said.
And has anybody got any good answers for the lymphedema? Dan?
Not a good answer.
We?
I don't have a good answer for the lymphedema. I want to ask about the first web space. Can you go back 2 slides, please? So what did you do for the first web? Maybe 1 more slide. What did you do for the first web?
For the first web, we did not do anything. As you can see,
that was the point. If you go back 1 more slide, please. So it's just 1 more slide. The discussion earlier was so how am I gonna create a first web space? You know, what flap do I use? And I mean, I'm sort of looking at that, and I think it may look like a Syndactyly, but if you get the lacrimal probe in there, you may find there's actually a space, and the first web space is actually exists, and you don't have to do anything. It's just for the audience, really. Before we start thinking what kind of flap we need to use to create the first web space, it may actually be there, and it may actually be adequate. So
yes,
that's
and she's shown that very well. That on that one it is. It's just that the thumb is short. But you need to be thinking about what you might otherwise need to use for that. But I agree with that quite often you'll release it and it'll actually be quite good. The tissue in the base of that gap that you go into is usually pretty friable and miserable. And if you want to use it as a local flap, it's not great because it's been all enclosed and horrible. And my impression as well, these patients get a slightly higher rate of infections than normal, probably because you really can't clean out that space properly. And you just have to accept that they're going to maybe have a slightly higher rate of infection, a bit longer to heal. But in this one, you've got a decent web, and particularly because the index and middle are so rubbish that actually they're not using that as a part of a web space. So you don't need that extra because the web space is effectively as far as the ring.
Yeah, I agree with Dr. Gill. Actually, we recently had an adult with a constriction ring in Syndactyly. So he's around 35 years of age, and he came with cellulitis in the hand because of all the dirt that had been there inside the web spaces because he couldn't clean it properly. And then we admitted him, gave him some IV antibiotics for the first few days, and then took him up for separation of the acrosyndactyly so that he doesn't get it back. So I think we should leave it and then we should separate it.
Okay. And any more comments from the rest of the panel? Shilu or Nirona? Oh.
Great cases to see. Thank you, Monisha.
Thank you, Monisha. Great case.
Thank you.
Okay, do you want to unshare, Monisha?
Yeah, sure.
Now, have we got any questions? No questions? People have got...
One question was when in the cases of amniotic band syndrome with associated radial nerve or other nerve anomalies, when you release the radial band, the amniotic band, how soon after do you see any improvement in the cases that do improve? Or is it kind of across the board that there was poor improvement in all these cases?
So the cases that we got after neurolysis or nerve grafting, or as I said, a neurogen tube was also placed in one child, did not see improvement in the movements. So for a few children, we have done tendon transfers, but others are waiting for the surgery. So when we do the Z-plasty, in this case, we did not explore or we did not try for a neurolysis. Or in one case, we have done nerve grafting for the median and ulnar nerve. And during follow-up, we did not find any improvement. So that child is waiting for tendon transfer.
I've done one on the leg where I released the band and didn't realize that actually initially that they got sciatic nerve injury. And then we did neurophysiology that showed that things weren't right. And then I did it again 3 months later and showed an electrical improvement, and then did on-table neurophysiology and showed that I was getting one component was improving and the other one wasn't. So I grafted the one that wasn't improving. But in terms of, did I get normal? No. Did I get electrical improvement? Yes. Did that translate to clinical improvement? Probably it translated more to clinical improvement with release of the band than it did with nerve grafting. Possibly because that nerve was just so rubbish that the bit that had a chance to recover was recovering on its own once I released it. And certainly I will go down right to the nerve and the vessel and release if it's down, if the band is that far down, and you quite often find it is a lot deeper than you think it is when you look from the top. And it's just a question of how tight it is deep rather than whether it's there. Well, that's my impression.
So Jill, does your management depend on the age? Because some of these kids are older, like 4 or 5 years old, but many of these kids we're going to operate on because we see them and they have a palsy, and we're fortunate enough to see them at 2 months of age or 3 months of age. If you're operating them on that early, which I would, if they had some sort of neurologic deficit, does that matter in what you do?
Yeah, I mean, I likewise will be trying to operate early. I mean, if I think they've got a neurologic deficit, I'm going to be operating before 3 months if I can, as soon as I can get there safely for the child. And obviously in many countries they won't be turning up at that age. They may even be turning up at adults, where I don't think you're going to get a gain from a neurological point of view. Do you get a gain from pain if they have pain? Maybe. And certainly tendon transfer would be useful, and Manusha's shown that. I have had, because some of these will have significant vascular compromise, and I have had one where, or a couple where there was significant color changes, and one where there was definite pain. And once the band was released, and this was in a small child, but once the band was released, the color stopped being like that, and they didn't get pain anymore. So I think there are roles for releasing that may not just be related to whether their nerve's going to recover.
And fasciotomies too, also sometimes, because that band can be very tight over the muscle.
Yeah, I'd agree with that. Any comments from any of the other members of the panel?
There's one more question. Could we shorten the second and third ray phalanges to make the first web space look better in Manusha's last case?
Manusha, would you?
I think we would leave the rays as such. We wouldn't shorten it more. Yeah.
I think I'd think about it, but the only thing is they're now getting better quality eye fingers and things like that as prosthesis for adulthood. So should they want to wear them, it'd be a bit easier if there's a little bit of something to move at MP joint level. Because often when they're older, they don't like the fact that their hand doesn't look normal.
But from a surgeon's point of view, we might be thinking that it will give a nice curve here. For the parents, it is a digit. For them, it is the index finger, and the third one is the middle finger. So I think for the parents, if we say that we are going to remove it, I don't think they will. It's not needed as well.
And I think particularly 2 digits, because it doesn't notice so much if you've got a 4-digit hand, if they look relatively normal, but a 3-digit hand does notice more, quite significantly more. And as I say, when they're older, that is often an issue.
Sure.
Okay, can I just share screen again if I can make that? Let's see if I can share. See where I want to get to. There we are. Let's see. There we are. It works this time. So in summary, amniotic bands, you're going to get amputations, you'll get deep rings, and even if they look superficial, they may be deeper when you get in there than you think. You will get lymphedema, for which none of the panel have got a great answer. And you will get acrosyndactyly, which might disguise more that you've got more than you think you have there. It's often that Syndactyly is mistaken for this, but it is quite different in appearance, and you just don't get those rings the same way. And there you often get little nubbins, and you're not going to get the acrosyndactyly, you're not going to get the lymphedema. Amniotic bands can be associated very commonly with talipes equina varus, and sometimes with cleft lip and even with facial clefts. And what sort of scarring you get on type is dependent on what sort of release you do. And I think there's a question of what the skin scar looks like. There's also a question of what the contour looks like, because that's really important for most of the children and the families. And then if you've got a nerve injury, I think we're all in agreement that the outcome is less good than you'd like it to be, and certainly less good than you might expect it to be, whatever you do, whether you just release or your nerve graft. But these patients, compared to Syndactyly patients, because proximally they have normal structures, will do pretty well where there's a good indication with free vascularized toe transfers, like the one that Manusha so clearly showed. So I'm assuming from Suzanne that there's no more questions. I do want to thank you all for listening. It's been, I hope you've enjoyed it. I hope we've answered some of your questions either via the question and answers or live. I would like to thank some people. I'd like to thank Emily Larkin, who set up the webinar. Who I wasn't expecting to be on it, but has helped with advice. Suzanne, who has been the voice that you've heard some of the time with the questions, and Alex, who's hidden himself in the background, but has actually been launching the polls and working with the polls, and also some of the more technical side of things. And I also want to thank Jonathan Jones, who's the current person in charge of the Overseas Committee, and is also someone I worked with many years ago and was an absolute pleasure to work with. He was originally going to be on panel because he thought you needed someone normal that didn't do the exciting stuff, but I think he was a bit overawed by the quality of the panel from overseas in particular, and has run away to have another meeting instead. So I want to thank all of them. I want to thank you for listening, and I want to just let you know that there's going to be another BFIRST webinar. Now this one's going to be quite different. This is on carpal injury and perilunate dislocation, and that's going to be Saturday the 26th of November, and it's going to be a very similar time frame. So we would love your feedback. We'd love to know whether you enjoyed it, whether you didn't enjoy it. You know, we want to know whether this is what you want for the future. And I hope you all have a very lovely weekend, whatever time zone you're on, and that you've had some fun, because I think we've all had some fun in this, and hopefully we've all learned something too. So thank you all for coming. For once in my life, I'm actually going to finish early, which is probably never happening normally. So please remember that date, the 26th of November. I want to give a huge thank you to the whole of the panel, but particularly Shilu, who has come despite illness and other issues. And I'm really grateful for all of you for the hard work, for those that got picked on to answer questions, and those that provided such wonderful cases. And hopefully we can all learn from each other. So thank you, everybody.